Good morning. Welcome.
Good
I am very
morning.
happy to have Valerie Cadet with me from PCOM, Georgia. Dr. Cadet is a PhD in infectious diseases and has been educating us about coronavirus and what's going on. So welcome, Dr. Cadet.
Thank you.
Dr. Cadet, what is going on with coronavirus?
So what's going on is that we have this virus that is a virus in a family of viruses that we've known before, but it's brand new. This particular one has never been seen before in humans. And so now that it's emerged in humans for the first time, it's causing widespread illness. Well, at least it's causing widespread, disruption because nobody has seen it before.
When you say it's brand new and no one's seen it before, we know coronaviruses, we know paramyxoviruses, we know, isn't this the virus that causes the common cold?
Well, yeah, we actually have 5 human coronaviruses that we know very well about. If you picked up a bottle of, any sort of cleaning solution, a lot of them will say effective against human coronaviruses. And for the most part, they do cause common colds seasonally, just about every year. The thing about it is that this is a brand new virus in that same virus family, that what we're seeing is because we have no pre-existing immunity in our population, it's sweeping through pretty broadly, and it is causing, more mild symptoms similar to a cold, or, maybe a more severe cold in a lot of people, but it's causing more severe disease in others. And frankly, this isn't the first time. So coronaviruses are actually typically going to be found in animals. So there's lots of coronaviruses in cows, in bats, in cats, certain types of cats, and other animals. And what ends up happening is that these viruses have eventually made the jump, let's say, from the animal species to humans. And that's where we've gotten the bulk of the 5 that we already know. But prior to this particular outbreak that we're experiencing now, we've had 2 major situations back in 2003 with SARS coronavirus, and in 2014 with MERS coronavirus, where again we had a brand new coronavirus, not one of the ones that were already circulating causing common colds, and they cause more severe disease.
So would exposure to coronavirus in the past make you more likely to have some cross-reactivity and protection from this coronavirus?
It's really hard to say. My gut says probably not, just because studies have shown that population studies have shown that when they're looking for exposure to coronavirus, when we're talking about the 5, one of the 5 that cause common colds, for the most part, most people have been infected with one or several of them over time. And so if we kind of took those studies that have been done in various locations and we expanded that to say that most of us have already been exposed to coronaviruses, well, then that probably wouldn't hold true, because a lot of us are still susceptible to this particular coronavirus, as we can see looking around the world, and as we're seeing it spread throughout the United States.
Beautiful. And you said it lives in animals like cows, bats, and cats?
Just to name, a few, but yes, cows, um, camels. In fact, the MERS, Middle Eastern Respiratory Syndrome, actually, was an emergence from camel. Now we think that, so there's a couple of different, clades of these viruses. So the ones that we've seen with SARS, with MERS, with COVID-19, as well as, a couple of the 5 that are circulating causing common colds, we believe that they emerged originally from bats. So the idea would be the bat is infected, and then the bat, somehow there's a transmission to some animal, for the most part, most likely, and then from that animal to humans. And so in that case of MERS, for instance, we saw that from camels to humans. As of right now, we don't know if that is in fact the case. It looks like it's likely the case, but we still have to identify an animal species and find the bat host.
If it has an animal reservoir, will it be here all the time or will it still be seasonal?
Well, again, that's a great question, but we don't know the answer to that. What we've seen with SARS and this particular virus, which is actually SARS coronavirus 2, that's how it's been named. And that SARS coronavirus 2 is what's causing COVID-19, which is actually the disease. SARS-CoV-2 is was so named because it has the closest genetic similarity to SARS. What we saw with SARS is that it sort of, it caused disease and then it went away. So it hasn't been resurging as a seasonal occurrence. And we actually saw the same thing with MERS. So, and we believe that both of those were from a bat to an animal, then on to humans. So if we're following suit, hopefully it does not necessarily stay and, become a seasonal sort of epidemic, but we really don't know. And we don't know if there's an animal host.
So I'm trying to figure out the life cycle that virologists like to put together for viruses. Do we understand it yet, or how similar is it? Do you want to talk about life cycle?
Well, so we know about, in terms of the infection cycle, somewhat, we're gathering more information. What we've seen is that the virus is, of course, it's a respiratory pathogen. So when one is infected, the virus is going to, enter, it's going to begin replicating. It uses ACE2 as the receptor to get into the cells. So it actually, it embeds into the cells, penetrates, and goes through the typical life cycle of viral uncoating and then, um, replication of its nucleus and making proteins. And then it's going to reassemble and exit the cell. Lots of virus will exit, from one viral particle coming in. So when that ends up happening, what we're actually looking at is a situation where once one is infected, it's anywhere from 2 to 14 days before they're going to actually experience those first symptoms. And that's why we're looking at that 14-day period of self-isolation if you believe you've been exposed, because frankly, that's really wide varying. We've seen an average of 5 days from the cases in the United States, as well as cases, we'll say 5 to 6, depending on the country from the data that I've seen, number of average days, but it's still really wide. We've got 2 to 14 days for most.
So when we talk about spreading disease, we talk about 80% of people who develop COVID-19 will have a mild upper respiratory, 20% will develop pneumonia. And in the medical world, we talk about how does one become the other, and it's always aspiration, inhalation, hematogenous, and contiguous. Is this only respiratory, or is this going to be in secretions? Is it going to be in the blood?
Great question. Well, actually, what we're seeing, as far as what I've seen, it is in the respiratory secretions. It's in droplets, it's in nasal secretions, it's in lung secretions, but we've also found it in feces. So, we're seeing it there as well. In a small number of cases, don't have the percentage off the top of my mind, but in a small number of cases, we're looking at some people experiencing some GI disturbances as well.
That was my next
So
question. If it's in the feces, why don't we see more GI? But you're saying we are.
we are seeing some. We are seeing some, and that's how we started. I believe that's kind of what led to testing to see if it's in fact present, because there are some cases of diarrhea and perhaps other low-level GI cases, but that's not in the vast majority of patients, actually.
And one of the things that's scaring me as we look at the symptom list, 97% should have a fever, 30 some odd percent should have a cough. What's in between?
It's really a wide range of people. I mean, I think that I've spoken with a lot of people, and a lot of us now have, know somebody who's either a presumptive case or somebody who's confirmed. And, the symptoms are varying from person to person. Luckily, so far, those that I have personally encountered who are, confirmed or presumptive are not at the more severe end yet. We're seeing that, the average, a major study that came out in China, I believe it was, oh, I'm horrible with dates right now because it's not in front of me, but it had to be recently, right?
Uh-huh.
This major study came out where they looked at a vast majority of patients, and what they've seen, the ones that were hospitalized, of course, and what they saw was that there's an average of 9 days. So everybody's getting sicker. If you're going to get sicker, it's happening in the second week, right? And on average of 9 to 12 days after you initially had the symptom onset is when you're, at that point having to be hospitalized, and then, care being taken to the next level.
Interesting, because we talk about 900,000 hospital beds, 35 million admissions. Average admission is 8 days. And we are hearing that the admission for COVID-19 is expected to be longer. Is it bimodal, where if you intubated, it's going to be much longer, but milder for others? Or is it most people who make it into the hospital are going to be there for more than 8 days?
Well, so what we're looking at, what I've seen is that, as you mentioned, about 20% of people are expected to have to need that advanced care. Of that 20%, the estimate has been about 5% of those, or I guess, those people are actually going to need the most acute advanced supportive care. And those are the people that can be in the hospital, we've seen up to 6 weeks, in fact. But the people, the bulk of the people, that 15% that actually are getting hospitalized are going to be there. We've seen an average from 3 to 4 weeks, so
Really?
more than the 8 days.
Wow.
But some of them are much shorter. It's really hard to say. And at this point, it's kind of like, we're just pulling all the data. We're always, of course, a step behind because that's what data is. And we're just looking at what we've had. Have there been cases where somebody was admitted and then, they were actually cleared within a few days? I did see a case report on that, but majority of cases are, yeah, longer. So our system is potential to be extremely taxed.
And we've heard anecdotal data about patients in China that if they were smokers, they're intubated longer. And there are some subpopulations we're identifying at greater risk. Who would you say are the subpopulations that have to worry the most?
Well, the smokers, absolutely. And we actually saw this as well with MERS. We saw that smokers fared worse, and had a longer time frame to recovery overall. And so additionally, the populations at risk are, of course, those who are immunocompromised. That could be for HIV, because they are HIV infected and have advanced disease, because they are undergoing treatment for various cancers, because of other, sorts of illnesses where they have to be on immunosuppressives like, steroids or other things. There's a variety of reasons. So those people, of course, people who have hypertension are considered at higher risk. People who have cardiovascular disease, and that covers a pretty broad umbrella, they're considered at higher risk. Type 2 diabetics as well as 1, so diabetics in general, and those who have lung diseases. Even something as, what someone would say as simple as asthma, that predisposes you to have potential for severe complications.
So a lot of the focus right now is prevention and stopping the spread, flattening the curve of how many people get sick all at once. When we talk about infectivity, how does one spread the virus besides respiratory droplets? Does it live on hard surfaces, soft surfaces?
So that's called fomite transmission when we're talking about just touching a surface and then perhaps, inoculating yourself with it, of course, right? So I've already scratched my face during, our talk here. I'm doing much better. I hold my hands to prevent that, because those respiratory droplets that we are breathing out all the time, or sneezing or coughing out, are going to contain the virus, and so they're gonna land on surfaces, and it can be both hard or soft surfaces. And they can live on those surfaces. Now, how long they live on the surfaces can actually vary depending on the surface. So, and we're still doing a lot of testing. I've seen various tests that say that there's a distinction between, for instance, certain metals versus plastic. I don't know. I don't think we have that hard data, but we do know that the virus is. We believe the virus actually has a potential to linger in the air up to 2 to 3 hours. That's number one. So that means
2 to 3 hours in the air?
2 to 3 hours in the air. So there's preliminary data that's showing that that's a possibility there, that we may be seeing 2 to 3 hours in the air. And then those droplets can actually, of course, come down and land on various surfaces. And we know that the coronaviruses in general, can live, up to 9 days. I think that we're seeing with this virus, up to 5 or 6 days so far, but we know some coronaviruses can live up to 9 days. So we're talking, let's say a few hours to days for certain.
Wow, that makes it very difficult to protect against.
It is. And so that's why everybody is screaming the words of washing your hands, soap and water. And so, right now we have this major shortage, of course, of hand sanitizers and cleaners and disinfectants and things. But actually, if we just think about it and use soap and water, because everybody's got an abundance of soap and water, in the stores, they're still present, then we can actually still wipe surfaces, wash our hands frequently, prevent touching our faces, because if you do touch a surface, you don't want to inoculate your eyes, your nose, your mouth. You want to prevent that infection. And then if you're just washing your hands frequently, that will help because you very well may come in contact.
What about spraying the air?
I keep hearing that question. And there are certain, cleaners and disinfectants that say you can just spray the air. I personally, I've never utilized them, in my scientific experiences. That's not something that, we use. We don't spray the air specifically. Now there are certain instances, of course, where that is part of it, but in general public, really think about it, even if it's in the air, it has to come down. So if you are cleaning your surfaces, wiping things down on a regular basis, in particular, what we call those high touch areas. So all the handles, the door handles, the handle, the cabinet pulls, your cell phone, that's a big deal. Washing your hands in between touching people. Stop touching people. I'm a hugger personally, but I've got to take a step back, right? We just have to do that. If you're cleaning everything regularly, then I think that we don't really have to worry as much about, you know, trying to sanitize the air, let's say.
So let me take you back to viruses a minute, just because from a primary care understanding of viruses, I think of a virus as a protein casing with RNA inside. Um, and then when we start thinking about how it's transmitted, the virus casing breaks open and the RNA invades our cells and creates an ooze, which is then fodder for secondary infections, bacterial infections.
Absolutely.
Can you start helping me think through the viral infection?
So for the viral infection itself, the virus, as you just mentioned, so it's got to have a receptor, and coronaviruses, utilize a couple of different receptors depending on the virus, right? So this particular one is using ACE2. ACE2 is found on a variety of cell types. It's found in abundance on our cardiac cells, as well as other areas of our body, which is, why we're seeing, people with cardiac um, pre-existing conditions being potentially at greater risk, as well as people with lung disease and even the GI. It's found, some cells with ACE2 are going to be found in our esophagus as well as in parts of our colon. So we have the cells throughout our body. The virus is going to bind, and then it's going to penetrate inside the cell. And as you described, it is going to, I call it unencapsulate, basically. So the capsid is going to disintegrate, and that's going to release the viral genome inside the cell. And so this is an RNA virus that's going to replicate in the cytoplasm. And so it's going to go through its full cycle. It's going to make RNA, more RNA. It's going to make its proteins that it needs inside the cell. So it's basically hijacked the cell. But the cell is still alive at that time. Of course, it has to stay alive for this to happen. And so when all those viral particles are made and reassembled completely, then it's going to leave the cell. And when that happens, now you've got a situation where you've got, potentially thousands of viral particles able to just go right along and infect any other neighboring cell that has ACE2 on its cell surface. And that's just going to continue. So is that getting at what you were asking?
Well, that raises two other areas of thinking, which is one, does it attenuate after each person gets infected? Because we usually should say the first person and the first row of people you co-infect have the worst disease, and it gets softer and milder each subsequent case. Is that going to be the case with coronavirus?
Not specifically. If it was the case, I almost feel like we might have already seen that early on in China, perhaps before even recognizing it as, this major new pathogen. What we're seeing isn't necessarily an attenuation just yet. It appears as though people still have the same potential, excuse me, for the severe disease if they have those pre-existing conditions, because at this point we're way past that front line of people, and we're still seeing the same type of illnesses, if that makes sense. Although, to be clear, the vast majority of people have still are, some are asymptomatic, some are mild, and some have, maybe an elevation of mild where they may experience more flu-like symptoms, but they're still perfectly capable of remaining home and, getting better, if that makes sense. But I don't know. I don't think that we're seeing that, what you've just described.
Interesting. And the other line of questioning is about developing a vaccine. Do you develop a vaccine to the protein, to the RNA, or do you actually take the blood of people who have recovered and look for antibodies?
Well, and so this is one area that I still have, to start digging some more deeply into because there hasn't been a ton yet released on what exactly is going on here. Just that we know that there are a lot of people who are working on the vaccine. So, in answer to your question, what do we do when we've had similar types of outbreaks like this? Well, people who have recovered, of course, have antibodies. So those antibodies, when necessary, could be utilized to help others. And they could also be utilized, to see if we could make monoclonals perhaps that are similar, to determine exactly what those antibodies were for or against, I guess, which in terms of the virus, what were they targeting? And are they neutralizing? Could we, recreate those? Now, is that actually being done yet in terms of, using antibodies to support other current patients? I can't speak on that specifically if that's happening, but that's one aspect. And then the other aspect is this. So for instance, we've got that spike protein, which is the protein that on the virus surface that actually is going to bind ACE2. Can we neutralize that
Mhm.
in some way? So vaccines targeted at the spike protein, are definitely being looked at. And there could be other aspects of this virus that we want to target depending on exactly, you know, what they're causing. And so right now we're just trying to study all the different aspects. But I know the spike protein is a definite potential target for a vaccine.
So did you want to comment on the increase in cytokines and peptides and what's being called a cytokine storm?
Well, so I've seen a couple of reports on that, and you know, eh, the last reports that I've seen, there's been this description of patients that are faring pretty negatively based upon the fact that they're having an extreme cytokine storm. I don't like the term storm, but essentially what that means is that their immune system itself is so over responding to this viral infection that they are secreting tons of cytokines that are, in many cases, pro-inflammatory, and it's creating a situation in their body where their immune response itself is actually causing such extreme detriment. And the why is this happening, hasn't been able to be clarified just yet, but we're seeing this cluster coming out.
Although the data from China showed that steroids didn't help, and if it was an inflammatory response, they should have had more benefit.
It should have. It's very confusing, actually. And so, in terms of really what's going on, I'd like to see some more reports. I think everybody needs to see some more reports. But the last that I've seen a couple of days ago were remarking on this, and things being contra to what you might suspect should be working actually, and it's just not. And it's not all of the patients. It's in some subsets of patients, but there's a lack of predictability in terms of who is going to actually have this response and why.
So in terms of treatment, we're seeing a couple of case reports of anti-malarials and people trying other things. Um, if you had to think through it, do you think anything is out there that's effective right now, or is it basically supportive in time?
Overall, it's supportive. I've seen the reports, a few of them on the antimalarials. I've also seen using HIV protease inhibitors, which makes sense because this particular, at least in theory, it makes sense. This particular virus is also an RNA virus that also encodes for a protease. So that potential for a protease inhibitor to help stop this virus from cleaving the proteins that it makes down to the appropriate peptide length would be fabulous. So we've seen some reports on that. Now, are those patients fully recovering because of these particular drugs and individually, or is it the combination of supportive care plus the drugs? You know, I don't know that that's been fully clarified, but it seems like some of those drugs are actually producing some success.
Interesting. So how do you see this resolving? Do you see the weather changing and when coronavirus season ends, or what do you think is going to happen in the near future?
That's such a great question, and everybody's asking. And you know, if we think about what we know about some respiratory pathogens, then we would say that there's a potential for, as the warmer months come, for the numbers of infections to decline, because that's what we generally see with respiratory pathogens. However, what we've seen with, so there, those 5 seasonal coronaviruses, a couple of them actually don't show a specific, propensity to decline in the summer. So there's a couple of them that, in temperate areas where it's really hot or even cooler, they're still circulating. So, even if that's the case where this particular virus, SARS-CoV-2, was actually going to maybe have a reduction in circulation in the warmer months, there's still parts of our country, if we just look at the United States, that, have more temperate regions. And so is that going to work? I'm not sure. It's kind of, we're really in a wait and see, and is Nature going to help us?
And I guess just a few last pieces to finish up. Why did it start in China, go across Europe, and come to the States later? Why were we protected for so long? And where do you see it going from here?
So why it started in China, in this case, so in China, they often have these live seafood, as well as live animal markets where, these animals, as well as, the seafood, and then of course lots of people are coming and they're commingling. Well, in these places, they also have the bats that we've seen. So we know SARS, for instance, we believe came in a similar type of transmission pattern there. So it started in China, of course, because that's where the conditions at this particular point for this virus were optimal. And then it spread through that population. But we're international travelers. I mean, this is such a global world. So there were people that were, of course, from parts of Europe that were in China at the time, or there were people from China that were potentially infected that traveled to parts of Europe. And so, I mean, they're closer than we are. So I actually think it just, in this case, the spread travels, the virus is going to travel through a proximity type of spread in that case, which is probably right, exactly. So when we look at the migration, I mean, we are actually further away. So it kind of makes more sense for it to take longer. But, one thing is that has been said, if we look at, for instance, Seattle, which was the first major hot pocket of cases here in the United States, they believe that there were people probably walking around for approximately 6 weeks prior to the first cases being seen in Seattle. So, that tells us that, there's probably a lot more cases, and it probably came here earlier than we even know. But I think it's looking at migration patterns and just geographic distribution.
Any final thoughts or things people should be thinking about with coronavirus?
Well, in terms of final thoughts, I mean, the fact is that we are behind in terms of testing, and it is what it is. The NIH has Dr. Fauci has talked about it. All the leaders have talked about it. What we as Americans, I think, need to do is just take this seriously. In the sense of prevention, washing our hands frequently, cleaning surfaces frequently. In terms of mitigation, so many of us are doing this because our schools have shut down, or at least partially shut down in some ways. Stores are shutting down. What we need to do, I think, as Americans, as human beings, is kind of just use common sense and take a step back. This is serious. We have an opportunity to really, really slow down that spread. As you talked about earlier, we've got the potential to really overwhelm the system, because our hospital systems and our health system, because of the time frame that a severe patient might need to utilize the services, and how many patients may need to utilize the services. And so if we just take a step back and maybe pay attention to our social distancing and the cues that the CDC is giving us and our health departments are giving us in terms of what to actually do, I think we have an opportunity to slow this spread down and to kind of flatten the curve, as you described.
Dr. Cadet, thank you for your service in educating osteopathic medical students and spending the time today. I really appreciate it, and hopefully we'll get to talk again.
Thank you so much. My pleasure.